Hi, Dr. Shirish.
Good evening.
Hello, Dr. Shirish.
Good evening.
Good evening, Doctor. Nobody else has joined. Can you please check?
What to share?
Dr. Neelam hasn't joined.
Okay, we'll have to text her. We'll have to text her. Okay. Let me see.
Yeah, can you please ask her to join?
Sure. Can we start?
Yes, please start.
Dr. Neelam is joining. She said she's joining. Let's wait for 1 minute.
registered on what you sent up. It gets very difficult to join. I'm registered and I'm waiting. Why can't you simply give me a link where I can click and join the link?
क्या हो गया? अरे साहब बुखार बहुत बोलो या तो जी भेजो
सर गैस इस बार है फिर में जाला
कब से हो रहा है?
दूसरा दिन से चक्कर भी आ रहा है।
ये तुमको सब सही है सब मैं चक्कर बस इतना ही बोलूं करके अब और नहीं भेजना अब रोक दो उसके लिए
ऊपर डालो. Hi. Can we put some books below this? Hi.
Good evening, ma'am.
Very good evening. Isko, I think give this to book. Let me put it like this. Put that book here. You open, try in that thing if it opens on the on the. Okay, let me mute this. Am I?
You are muted, ma'am.
Yeah. Hi, everybody. Am I supposed to start, Dr. Suresh?
Yes, ma'am.
Well, it's my pleasure to introduce Dr. Suresh Bhattnagar, the able secretary for Indian Society of Pediatric Gastroenterology Hepatology, and an excellent pediatric gastroenterologist who's been practicing in Lucknow and has been doing a lot of good work. Today, he's going to provide us his in-depth knowledge on a very interesting topic about whether there is any role between diarrhea and dysbiosis, whether it is dysbiosis giving rise to diarrhea or diarrhea giving rise to dysbiosis, whether it's a nitrogenic cause or infective cause. And let's hear what his views are today on this interesting topic. And we do have others to join us. Dr. Janani, I can see, besides the people from the digital media. Thank you so much for giving this opportunity to us and under the banner of Indian Academy of Pediatrics, able leadership of Upendraji and President-elect Dr. Baswaraja and past President, who has envisaged all these meetings. And this was a pure thought process of ISPAGAN, where we wanted to talk about dysbiosis, and so happy for Sirish to take this over. Over to Sirish.
Thank you, ma'am. Thank you, ma'am, for the kind introduction. And thank you to Central IIP and the IIP platform for giving this opportunity. Going away to the top, so when we see gut microbiota, we need to understand what this gut microbiota being. We have gone through this slide a lot of times, but just want to concise in 2-3 slides basically what exactly we are trying to say about the gut microbiota. So it's all mucosa is colonized with bacteria. If you see, the intestine is preferred site because most of 70% of all bacteria found in the body are basically in the intestine, and it's a large organ which is rich in nutrients. So that is why bacteria prefer intestine. And what we see is longitudinally bacteria increase in number and composition from proximal to distal. So you do not have bacteria in the esophagus, whereas once you see you go down from the stomach to the intestine, the count of bacterial count increases. So this is what is happening in the whole GI tract. There is increasing diversity if you see from the stomach going down to the ileum jejunum till the colon. Latitudinally also the bacterial colony also differs. So there are different bacteria which are there in the lumen, different bacteria in their mucus and the attached epithelium. So the entire, what I'm trying to say is that the entire gut microbiota is a dynamic composition, changing every day, every second, with every environmental interference. It is changing, and that we need to understand. So where do they come from? Initially, exposure occurs during the birth and is heavily influenced by mother and the environment. So all these factors are affecting. And if you are not breastfeeding, the contact with the cutaneous skin is not there, or passage of the child from the vaginal canal, if it's not a normal, all these factors are changing the entire gut microbiota. And that is why we say that all these factors are being, and early exposure to antibiotics, which is very common in children post cesarean section, is also a very common factor which is changing the gut microbiota. And this is how the whole gut microbiota changes as age-wise also. You see from birth to 12 months, gradually all the type of bacteria are increasing in quantity. So what does the gut microbiota do? It basically helps in the metabolic capacity, completes the bile salt acid cycle, protects the host from colonization with pathogenic organisms. It helps in immunity. We're not going into details of the immune system. Now comes what is dysbiosis. So once we know what is a normal biasis, what is a normal microbiota, dysbiosis is alteration of microbiota from the normal health state, a condition of microbial imbalance rather than equilibrium between the good and the bad microbes. So what we see is that dysbiosis could be a change in the loss of beneficial microbiomes, reduced diversity, or pathobiont expansion. So anything of these factors is called as dysbiosis. So dysbiosis is a varied spectrum, if you understand. Now coming to the crunch of the talk. Intestinal dysbiosis has been implicated in many diseases. If you go down the list, not a single disease has been left where research has not said that the dysbiosis. But as a pediatric practitioner, where does intestinal dysbiosis play an important role in terms of diarrhea? That I'll try to focus. So when there is dysbiosis, there are agents of rebiosis. We have some things which will help us to rebiosis. One is prebiotics like fructooligosaccharides and guaiac electrodes. There are certain drugs which have been used as rebiosis agents like simvastatin, metformin, rifaximin, and folic acid. Fecal microbiota transplantation or Clostridium difficile, which has been used, and hepatitis, and finally is probiotics. So all of these armaments we have where we can use them as agents of dysbiosis. Now, as there are a number of diseases where dysbiosis has been implicated, similarly, probiotics being used as a treatment of rebiosis, there is lots of studies and lots of conclusions. We're not going to details again. However, what I was trying to say is the proven clinical impact for a pediatrician perspective, where we know that yes, probiotics or rebiosis will be helpful, is for the important purpose. So these are acute infectious diarrhea, antibiotic associated diarrhea, inflammatory bowel disease, prevention of NEC, and subacute intestinal and SIBO. So these are 5 clinical conditions where rebiosis has been proven to have some clinical impact, and I'll be discussing this in my next few slides. When we come to acute infectious diarrhea, I again reiterate that management of acute diarrhea still rests on the 4 pillars, that is use of ORS, continued feeding, do not use drugs, use of drugs should avoid it, and zinc. So these always form the pillars of management of acute diarrhea. We should not deviate on these pillars. These are the essential steps. So if a patient with acute diarrhea comes to you, always start the management with all these things rather than going with another entity. Now, what are the potential alarms within acute diarrhea? These are there. We all understand that if there is severe dehydration associated, then that is an alarm sign, and the patient should be managed in a hospital setting. Now coming to what we had discussed, we had discussed that use of ORS, all these things very important, but what are the studies saying that? Studies says that ORS use is still down 55%, zinc is around 25%. This was a study which is of 2011. What has scenario changed? Has the scenario changed from 2011 to recently? So this was a study which was done as the REMAD study, where where it was found out that viral is still the most common etiology of diarrhea, and the ORS use has now gone up from 25 from 50%. It is now gone to 80%. Zinc use has also increased from 25 to 83%. Probiotics are being used around 76%. Antibiotics are still being used. Antiemetics are still being used. And the good thing is that anti-motility drugs, their uses has considerably gone down in a number of uh, across all country practice. So this is an important change which has occurred over the last decade or so, that yes, the use of zinc and ORS has increased, but we need to increase it more to make it 100%. And that is very important in terms of management. Now coming to certain conditions, certain issues which are discussed in diarrhea, what is the role of early versus delayed feeding? So there is always a taboo of restriction of feeds in diarrhea. So what was basically, this is a Cochrane data which clearly says that if you start feeding in a patient of acute diarrhea early, that means less than 12 hours, it has been shown that there is no difference between need of unscheduled IV fluid or incidence of vomiting or development of persistent diarrhea or length of hospital stay. So very clearly it states that if you start feeding, it is early. So what we say that as soon as diarrhea starts, feeding should resume also. Do not stop feeding, because if you stop feeding, it won't have of any beneficial effect. So always make it a point that in a child who is having diarrhea, feeding should be continued, and it has shown to be of beneficial effects. Restriction of lactose products. It is a very important taboo which is there. Whenever the diarrhea starts, we tend to stop lactose products. So it has been seen in multiple
I think the recording got hung. Sirish, we can't hear you. Somebody from the digital side, is the problem your side also?
Yeah, doctor, there's some issue with Dr. Shiri's.
Yeah, so I thought it's not at my end. So just we need to communicate that we can't hear him. So just while they are trying to find out what is the issue, I just wanted to recapitulate what Sirish has talked to us. That one of the good things that he showed in that study was that even though the antibiotics were being used, 80% of them were used when there was presence of blood. So that's a good message that over and over again, the various efforts through reach to all the doctors digitally has been proven effective, because as you can see that ORS has been used in close to 80% and zinc more than 80%, and I wouldn't say 100%, because at times when you have vomiting, you don't like to give zinc initially because you're worried, and then you subsequently like to add that, and it does give rise to gastritis. So I don't know which time the survey was done, but I was quite happy to see about the antibiotic, and it did message that 3/4 were using probiotic. That was quite surprising. I didn't know that 3/4 people use probiotics in this conditions. And in addition, very interesting facts we've talked about is how uh, your your gut microbiota changes during different phases of life, right? Starting from in utero and then in birth, depends on what type of delivery you've had, whether you had a delivery which was through the vaginal route or the cesarean route, and whether you were in the nursery, whether you had any introduction of top milk or breast milk. It goes without saying that, breast milk, and breast milk is most important to get is the best of microbiota. So if you look at these studies which talked about the different, like the proteobacteria, bifidobacterium, and firmicutes, etc., there is a spectrum which is changed in the babies who's received breastfeed versus those who receive top feeds, and babies who's received antibiotics. And we have enough literature now to show that if these babies in early childhood have received, Shirish, I hope you're able to join in because I'm going on Extreme 4. So these babies, when they receive, they have a tendency to obesity later on. That is also very interesting. Not only do we have evidence to show that preterms have a tendency towards gaining weight, but now we have literature to show that if you had excessive use of antibiotics in the first few years of life, then the tendency for you to get overweight, obese is high because there is a change in the microbiota that happens in the patient. So I think this is what Sirish was talking to you about. And I hope somebody from the digital, can you tell me what is the status? Hello?
Net error. I don't know.
Oh, Sirish, I'm so happy to hear you. I went step 4 talking some thing about the dysbiosis.
I'll just get back.
So even if you don't show slides, it's okay. You can read out to yourself and come. So thank you for the patient listening to me. And now hopefully Siri should be able to join back and discuss. Yes, I can see the slides. Sirish, if you want to switch off your video so that more of energy is spent into the other thing.
Okay.
Yes,
so
go ahead.
sorry for the trouble with that, some disconnection. So basically what we were discussing is like yes, we were on this slide that the anti-secretory agents, as the IAP consensus statement says, that with current evidence, anti-secretory secretory agents are not recommended for treatment of diarrhea. There are 2 anti-secretory agents which are there, which have been shown to have some beneficial, but all this has been on only on certain studies which are not of clinical, more of clinical. So that needs to be evaluated at a level of higher magnitude. Coming to probiotics, whenever we introduce or tend to introduce a probiotic, there are certain confusions which come to our forefront. In terms of physicians, we have what is the duration, what is the dose, and what is the strain. And in the terms of patients always analyze it, what is the cost of probiotics and what is the cost versus benefit analysis. So if you see the evolution of probiotics basically were introduced in 1997. In 1977, it was 1997, there was no indication of use, only ORT was. In 2000, probiotics came as an helpful in antibiotic-associated diarrhea. In 2004, probiotics were helpful in adult diarrhea. And from 2009, it is sort of an add-on therapy in childhood diarrhea. So what does the current status in 2023 say about probiotics? So if you see that probiotics in acute infectious diarrhea or probiotics in prevent antibiotic-associated diarrhea, there is no role of products with combination of probiotics and prebiotics. That is very categorical. No studies across the board has clearly said that any beneficial is there when you need to add pre or probiotics. Whatever you give has to be a single strain probiotic which has to be given. What they have shown in studies is that there is decrease in the frequency on day 2 in certain studies, and persistence beyond 4 days is a little bit beneficial when you add probiotics. So what is the end line which most of the guidelines say? That with ORT, probiotics appear safe and beneficial in acute diarrhea, and the duration usually is for 5 days. So if you see in nutshell that this is what probiotics are helpful in acute diarrhea. Coming to Bacillus clausii, which is saying that it does reduce the diarrhea, reduces the hospitalization, and is a safe probiotics in acute diarrhea. There were studies which were compared between Saccharomyces boulardii, Bacillus clausii, and rhamnosus. And what they found is that the stool consistency on day 5 with Boulardi was around 10%, whereas with 50% in Bacillus clozi passed a normal stool. So the consistency improved better with Bacillus clozi. Same with the safety profile. There was no side effects or life-threatening problems with Bacillus clozi. So Bacillus clozi is a probiotic which could be used in treatment of acute diarrhea. Now coming to antibiotic-associated diarrhea. Here I would like to draw your attention. There are 2 scenarios where I would like to throw you. First is a 3-year-old child with history of fever, cough, 3 days, given amoxicillin, cetirizine, and paracetamol, and develops diarrhea next day. On the other hand, there is another child who is 3-year-old who was admitted previously with LRTI and was started on IV antibiotics. On 5th day, develops diarrhea with blood and stool. So which of them is antibiotic-associated diarrhea, scenario 1 or scenario 2? Now let us get back into the literature. What does antibiotic-associated diarrhea say? And then that will solve us what is exactly scenario 1 and what is scenario 2. So antibiotic-associated diarrhea, if you see the literature, incidence is around 20%. Incubation period of antibiotic-associated diarrhea in pediatric population is 3 to 9 days, 3 to 10 days, which is a little bit more as compared to adults. Etiology is 30% by Clostridium difficile, whereas adults predominantly is 50%. And what is an interesting fact is that around 67% of the neonates developed in hospital may be colonized with C. difficile, but rarely show diarrhea. So presence of difficile is not synonymous with antibiotic-associated diarrhea. Risk factors are age 1 to 4 years, comorbidity like IBD, exposure to antibiotics within last 12 weeks, specifically multiple antibiotics like penicillin and cephalosporins, and current hospitalization. And the presentation of antibiotic-associated diarrhea is diarrhea, abdominal pain, fever, and colitis. So ideally, if you see, it is the scenario 2, which is more of antibiotic-associated diarrhea. On the hand, scenario 1 is basically could be just a viral infection, which was earlier presenting as fever and cough, and then starts to develop diarrhea. So scenario 2 is the ideal situation where you need to think about antibiotic-associated diarrhea, and you need to start these children on the treatment on the lines of antibiotic-associated diarrhea. So what is the treatment? You need to stop antibiotics. Metronidazole is still the drug of choice in children, whereas in adults, vancomycin is now the drug of choice for antibiotic-associated diarrhea. And prevention is better than cure. So you need to use antibiotics with a judicious use, frame set of mind, and probiotics can help to prevent antibiotic-associated diarrhea. This is a very important thing. They can help to prevent. So what are the studies say? And Cochrane data says probiotics are effective for preventing antibiotic-associated diarrhea, decrease the mean duration of diarrhea by 3/4 of a day. Best preventive if co-administered with penicillin. So when you are thinking of starting a patient on penicillins or amoxicillin acid, and you know that they are being given for a longer duration, this child is in ICU setting, maybe suffering from pneumonia. There you need to start them on penicillin group of drugs, where you need to start probiotics along with antibiotics so that it will prevent antibiotic-associated diarrhea rather than thinking of treating it. So prevention is the modality where probiotics is of very much. Higher dose is more effective than lower dose. And there is no difference in incidence of adverse event between the treatment and control. So probiotics are effective for preventing antibiotic-associated diarrhea and can be given safely but we need to start them as soon as possible when we are thinking of starting them on antibiotics. So what does happen in natural history of diarrhea? Acute diarrhea usually 70% resolves by 1 week, 90 to 95% resolve in 2 weeks, only 5 to 10 become persistent. When it becomes persistent beyond 6 to 8 things, we need to think about other causes. So these are prolongation of diarrhea where you need to think about other causes, and referring these set of patients to a pediatric gastroenterologist is all the more important because they are differential diagnosis which only pediatric gastroenterologist who is trained in all these type of prolonged diarrhea can make a diagnosis and help your child get better soon. So coming to the persistent diarrhea, we all understand, we all have gone through this chart in our MBBS days where there is a vicious cycle between malnutrition and there is causing of diarrhea, persistent diarrhea, use of drugs, all these things. So this is a vicious cycle and we need to break in terms of persistent diarrhea. Very important fact is that what do we say about stool examination? Many of what we see in our referrals, that majority of that treatment is started on the basis of that the stool is acidic and you start. So there is no role of routine stool culture and isolation of pathogens in acute or persistent diarrhea. Stool for fungus can be done if you are suspecting difficile in a clinical setting, and opportunistic, you need to do 3 consecutive fresh samples for opportunistic infections. Indications for antibiotics still hold the same thing as age old. Blood and stool, if it is you are thinking about Shigella salmonella, systemic infection if the child is having, severe malnutrition, if there's concomitant UTI or the child is less than 4 months of age, then you need to start these children on antibiotics. There is no role of empirical nitazoxanide or cryptosporidium in acute diarrhea. Okay, now coming to another child which we just wanted to discuss. This is a child who is having 9 months old child having repeated episode of diarrhea for say around persistent and now has landed up into persistent diarrhea. Given multiple duration of antibiotics, cefixime or fluoxetine, but the diarrhea doesn't resolve and it became persistent. For now, it is for around 2 to 3 weeks. What we found on examination was, if you see, there was oral thrush and there was perianal erythema with satellite lesions along the flexures and scrotum and penis with curdy white lesions. So this is a child who is exposed to multiple antibiotics, small child exposed to multiple antibiotics with now develops oral thrush with satellite lesions in the scrotum and penis. So this is a child who is having fungal infection, which is causing the prolongation of diarrhea. So in a child who's having persistent diarrhea, we should always look for whether there is a fungal infection which is causing persistence. So we need to think about causes which are causing persistence of diarrhea from a normal diarrhea. And this child was treated with fluconazole for 10 days and the child had resolved within 3 days. On the other hand, there's a child who's having lactose intolerance. Why does lactose intolerance happen? You need to understand that there is lactase enzyme in the brush border. If because of diarrhea, this lactase enzyme is denaturated and the lactose load in the diet is not basically absorbed, this unabsorbed lactose goes into the colon, and in the form of hydrogen and lactic acid, you have this acidic osmotic stool. So the child basically present who is on lactose milk present as explosive stools with persistent diarrhea. So if you have explosive stools, perianal erythema, then this is the classical picture. You have explosive stools, perianal erythema, widespread. There are minimal lesions. Earlier picture which we showed, there was curdy white lesions in the scrotum. Here, the scrotum is spared, but you have perianal erythema. This is classical of lactose intolerance. No need to get a stool test done for pH and everything. This is a child who is classically having lactose intolerance. Please go ahead and treat on those lines. So this is what, which as I was saying, was different from the previous case. So dietary management in persistent diarrhea is the same age-old plan A, plan B, plan C. There is low lactose diet, going on to no lactose diet and monosaccharide-based diet at every 2 weeks. If the child is not responding at 2 weeks, can change to no lactose diet. Green banana is one of the very important, which has been done. And this is a study, beautiful study, which was done in Bangladesh for around 10,000, 12,000 children were recruited. And they found that if you give green banana diet to children who have acute or persistent diarrhea, their diarrhea tends to resolve a little bit better. Coming to probiotics in persistent diarrhea, it has been shown that the duration again by force and the steal frequency is reduced. So probiotics are helpful in treatment of persistent diarrhea also in a little bit of ways in which they can help. Coming to the third aspect, we have discussed acute diarrhea. Now we have discussed persistent diarrhea, then dysbiosis and IBD. We are now seeing a lot of cases of inflammatory bowel disease in our settings. A lot of children are coming with inflammatory bowel disease. And what we see is that there is dysbiosis, and it was been seen that children who have IBD are prone to have deeper ulcers and hepatic abscess, sepsis, endocarditis, opportunistic infections. These are more, and these are basically what have been correlated to dysbiosis. If the child has dysbiosis, then these problems of complications with IBD are more, and hence we need to correct. Adults have been using probiotics like VSL3. It have a beneficial role in induction and maintenance of remission in ulcerative colitis and pouchitis. However, there's no proven role in Crohn's disease. Rifaximin has been shown to be beneficial in induction and maintenance forms of remission of IBD. So both these drugs have been used as an agent of rebiosis in inflammatory bowel disease. In pediatric literature and adolescents, we are also using to certain cases these probiotics and been helpful in treatment. So most clinicians adult clinicians use antibiotics and probiotics and adjunct therapy in inflammatory bowel disease. Pediatric literature is not so much clear, but yes, it might come with future research. Probiotics for prevention of NEC, only randomized or quasi-randomized controlled trials that enroll preterm infants. Enteral supplementation of probiotics prevents severe NEC. So it is, remember, prevention. Again, prevention. As we had discussed in antibiotic associated, it was prevention. Also in NEC, it is prevention rather than curing of NEC. So if you are suspecting a child who is a preterm, who is less than 2.5 kgs, 32, 31 weeker, where you will have a chances that they may go into NEC. These are the children who can be benefited by supplementing probiotics. Now coming to the last scenario, which I like. This is a 10-year-old child, and this is a frequent complaint which you must have been seeing and encountering in your pediatric practice and OPD practice. You have a child who comes with, had an episode of diarrhea, then subsequently had, now what he's saying that loose stools, occasional abdominal pain, bloating in 14 days. And parents, what they say that after feeding, after eating, the child has to go to stool. The stool is formed. The stool is not watery. They may be semi-solid, or they may say foul smelling. They may describe it in different ways, but they never say it is watery. They only say that it is a little bit loosey stool with occasional bloating, pain, which is persisting. And what they say is that persist mainly occurs after eating. So what is this which is happening? This is child. So what we understand that this is suspicion of SIBO. These children could be having SIBO, where it is called a small intestinal bacterial overgrowth, which is a substantially underdiagnosed and mid-diagnosed entity, frequently implicated as a cause of prolonged diarrhea and abdominal pain. And it's characterized by increased number of abnormal type of bacteria in the small intestine. So this is basically what is happening is, because after an episode of infectious diarrhea, they are prone to SIBO, which later on develops to persistent diarrhea. So how do we treat SIBO? Basically, correction of underlying cause needs to be in nutritional support, specifically supplementation of vitamin B12, fat-soluble vitamins, calcium and folic acid, exclusion of lactose from the diet, reduction of simple sugars, avoid these, ask the children to avoid sugary items, and sometimes rifaximin may be tried. And the dosage of rifaximin SIBO in adults and children older is 12 years is 10 to 15. Younger children, a daily dose of 20 to 30 milligram per kg per day. And it is still not approved in children less than 2 years of age. What does rebiosis, summing up, what does rebiosis future implications? We all understand that rebiosis, as we know, has a lot of role in gut allergy, obesity, NASH, motility disorders, cancer prevention. So this is all open to research. Rebiases, dysbiosis is a very huge spectrum open to research, and people should come out with their own literature and try to prove or disapprove all these theories. To summarize my talk, I would say that human microbiome is a dynamic community. It is changing every day. Dysbiosis is a state of microbial imbalance. It could be one of the organisms which is growing, one pathological organism going, or the good microbiota is going down. So it can be anything of the imbalance. Rebiosis has a proven role in treatment of diarrhea, like acute diarrhea, antibiotic-associated diarrhea, and persistent diarrhea, IBD, and SIBO. Once Hippocrates said all disease start in gut, and the future says that probably the cure also. So with this, I end my talk, and I again thank the IIP team, Central IIP team, and Neelam ma'am for basically contributing to this talk. And sorry for the glitch which happened in between.
That was pretty quick and crisp. Thank you. Now you can join the screen online. You can open your video. I don't know how to make this more simple. Right. There you go. So thank you. That was very excellent. It was very crisp. There were a lot of, I highlighted all the points that you had spoken, I reiterated. And I guess, again, summing up what he said afterwards is two key messages he was trying to give about. So Suresh, before we open, Janani, you can take the questions. I want to ask you, you clearly emphasized that it had more role in prevention. And the very fact that you talk about dysbiosis is, change in the flora. So once it happens, you can't really do it. So in antibiotic associated or NEC with level A evidence in both, what is your take about the role of this thing probiotic in acute diarrhea?
So in acute diarrhea, what the studies have basically shown across different probiotics which have been used is that they have a role in like day 4 frequency. On the day 4, the reduction on day 4, like duration of usually what we see diarrhea. It's the diarrhea which what we see as we hear from the pediatrician friends, that anything which goes beyond 4 days, the patient starts to panic. So there what we see, the probiotics have a role in decreasing that duration from day 4 to day 3, and also in decreasing the frequency on day 2. So that is a little bit change what is there. So with this versus the cost benefit analysis that we need to always take into account, whether we need to introduce, yes, it has a role in these set of implications, but not in every diarrhea. That is very important to clear the message that not in every diarrhea of acute diarrhea we should start probiotics. It's only like we have to have the basic 4 management of pillars have to be started in management of diarrhea first.
Yeah, so sometimes I wonder that it's really very interesting because uh, is diarrhea going to give rise to dysbiosis, and will by giving probiotics will be help in the future issues? I'm not sure whether we've looked into this, and maybe it is time to do some studies which can look into that. Number one. Number two, I think I'm quite convinced that once when you use this antibiotic, then definitely because antibiotics are going to give rise to dysbiosis, it may be a, a, a good thing to start it, not only to reduce the incidence of diarrhea, but also to prevent dysbiosis, which can have its repercussions subsequently. These are my thoughts. I always keep thinking about that it needs to, and we need to look probably into those studies which I was talking about, that if we used it in the cohort with or without, even though the reduction, but what was the long term in the next 6 months or 1 year, how did they behave? That would be very interesting, because we did 2 studies when I was working in AIMS at that time. Dr. Ban was doing the zinc studies and all. And there are a lot of studies which showed that when you give it not only during the diarrhea, but the effect of it is going to be subsequently in reducing the uh, infection. So, I think there is a need to do that. But his studies were quite a lot sponsored by WHO, UNICEF, etc. And these studies have to be uh, non-drug sponsored studies to get the right answers. So, do we have any questions? Is Janani looking after it, or do we have any more? Because I can't see any questions in this chat box unless you all forward me, because the pediatricians have joined in another group, and who is going to share the questions? I'm not sure Janani is there, or it's just, her, this thing is, because I've been rattling a name, but there's no response. So somebody from the digital media IAP, can you just say that are there any questions that needs to be answered by Sirish? We are not accessible to the other chat box where the questions would come. So can you comment, please? Akshita is the girl's name. So Sirish, I apologize. Janani is just, on it and disappeared, so she's not able to give us comment. Last time we had Kalpana. She was looking into the other format. She had access to questions, and even this digital lady, Shweta, or somebody had access. Right now, I can see one lady in the IP host, but conveniently disappeared in both the thing. So thank you so much, Sirish, for this wonderful presentation. And I thoroughly enjoyed the way you delivered your speech. It was really very crisp and very nice. Thank you so much for this opportunity for me to chair you and learn so much from you. Okay then. Good night.
Thank you. Bye, ma'am.